It's 6 o'clock. This is Michael Poon. I'm the chief cardiologist of the Excelsior Healthier Heart Specialists. And today, we were supposed to have a talk by Dr. Wu on diabetic foot care, and he's no longer with our organization, so I will be giving a talk in lieu of his talk. I will be talking on how to assess for pulmonary hypertension. This is quite an important topic, and especially for the primary care specialists. This is my disclosure. Well, pulmonary hypertension is one of the diagnoses that all the ICD-10 codes belong to the HCC. That means you carry a higher risk adjustment. Therefore, for us as an organization, we carry greater reimbursement. So it would be very important to get this diagnosis and refer to the specialists, both the pulmonary, Dr. John Ashkar and myself, would be able to take care of this group of patients. And I'm giving this talk to give you some background and some of the hint on how to pick up patients with early pulmonary hypertension. Well, this is an autopsy of a patient of mine many years ago who died of pulmonary hypertension. And if you look at the heart, without the label, you would probably guess the big one is the left ventricle and the small one is the right ventricle. But actually, this is opposite. Patients die of pulmonary hypertension tend to have a very large right ventricle and a very small left ventricle. As such, most of the cardiologists we're trained to diagnose left heart disease often miss right ventricular failure or right ventricular pathologies. So it is important to know that. The symptom for pulmonary hypertension is very typical, and we see this all the time in cardiology. So it's nothing specific for pulmonary hypertension. Shortness of breath, chest pain, syncope, edema, peripheral edema, weakness, and early fatigue. So patients with pulmonary hypertension tend to have problem exerting himself or herself. And this is because of the limitation in the lung. The physical exam for pulmonary hypertension is really classic, is focusing on everything on the right heart. So you really have to listen to the tricuspid valve murmur. Typically, it's a holosystolic ejection murmur. You hear best at the right and left sternal border, and it gets worse with taking deep inspiration, because when you take a deep inspiration, more blood going through the heart, and patients with pulmonary hypertension would have more tricuspid regurgitation. The second heart sound, particularly the pulmonary component, will be louder. And if you look at the neck, there will be elevated jugular venous pressure. There's a classic Graham-Stew diastolic murmur, which is typical of patients with severe pulmonary hypertension due to the regurgitation of the pulmonic valve. If you put your hand on the chest, you could feel the RV heaves from the dilated hypertrophy right ventricle, and oftentimes you would hear a S3 or S4 gallop from the right heart. You look at the finger, you might see the clubbing, which is a sign of some kind of congenital heart disease leading to clubbing, and which also give rise to pulmonary hypertension. The EKG of patient with pulmonary hypertension is classic, and you always have to remember the 4 R's. What are the 4 R's? The right axis deviation, okay? Right axis deviation in this typical EKG of someone with severe pulmonary hypertension, you see the negative force in lead 1 and positive lead force in AVF. So with lead 1 down, AVF up, that's right axis. So it's the right axis deviation. You also look for right bundle branch block, okay, what we typically call rapid use, so like this EKG on the bottom left. This RSR prime pattern is typical of a right bundle, suggestive, not conclusively, but suggestive of the presence of pulmonary hypertension. Right ventricular hypertrophy in the EKG on the right, you see tall R wave in lead V1, which is typical of right ventricular hypertrophy. That means the force is more, the V1 is right where the right ventricle is, and is very prominent. Right atrial enlargement, right, because your RVs dilate and hypertrophy, your right atrium as such is also dilated. So the EKG finding is a tall P wave, like this one in 2, 3, and AVF. So tall P wave in 2, 3 AVF, right axis deviation, right bundle branch block, and RVH are the 4 classic EKG for patients with pulmonary hypertension. If you see anything like that, refer the patient to a cardiologist or pulmonologist for evaluation. The chest X-ray is also very classic in patients with pulmonary hypertension, and this is a typical pulmonary hypertension patient. You look for right atrial enlargement, so you can see the silhouette on the right chest. Okay, very prominent right atrium enlargement. And the pulmonary artery is very prominent. This is the right descending pulmonary artery, and then the central pulmonary artery is very prominent. And you also see relative hypovascularity, okay, oligemic in the peripheral vasculature. Because of the long-standing pulmonary hypertension, you have vasoconstriction in the distal small vessel, leading to the hypovascularities in the peripheral vessel that you can detect on the chest X-ray. And don't forget to look at the lateral film of a patient with pulmonary hypertension. They have a classic obliteration of the anterior airspace, which typically is lung, but now is replaced by very enlarged right ventricle. So this is a very classic X-ray finding of someone with significant right ventricular enlargement. And then on the echo, this is the forgotten chamber that we often call, because cardiologists typically train to look at the left heart, so we often ignore the right, and we blame it on the echo windows, not able to see the entire right ventricle. But you can get a sense that the right heart is significantly larger than the left, which is not normal. They should be about the same or even smaller. The right ventricle should be smaller. And when you put a Doppler echo along the tricuspid valve leaflet, you would see a tremendous turbulence of tricuspid regurgitation, as shown here on the right. So this is classic picture of someone with severe pulmonary hypertension and tricuspid regurgitation. CT scan is very useful. We use it to diagnose many lung conditions. In pulmonary hypertension, one of the major causes of pulmonary hypertension is pulmonary embolism. So this is a clot sitting in the right PA and is obstructing it. It's actually a patient of mine that I saw many years ago who took a birth control pill and developed acute pulmonary embolism. And the picture on the right is someone with constrictive pericarditis from some kind of chronic infectious etiology, and it could be TB, and the patient developed very thickened pericardium. And because of the thickened pericardium, it is compressing and then causing the heart not able to fill adequately, and that could also lead to development of pulmonary hypertension. This is the MRI image. Excelsior is one of the few centers in New York that can do very high quality MRI scan. As you can see, the picture is very, very clear. You can see the picture on the left, a normal heart, very round left ventricle, and the right ventricle look like a slice of pizza. But in patients with severe pulmonary hypertension, the right heart becomes very large and the left heart becomes small. And if you just look at the left heart, you would mistaken that everything is okay. But if you just look next door, the right ventricle is very hypertrophy and large, and you have development of pericardial effusion, okay? And our right ventricular hypertrophy, and what classically described as a septal bowing. The septum, instead of circle, now become a letter D, a D-shaped bowing of the interventricular septum. This is a classic picture, both MR or echo or CT of someone with severe pulmonary hypertension. Well, the etiology, the pathogenesis of pulmonary hypertension is very numerous. In a way, it's very similar to atherosclerosis. The difference is in atherosclerosis, the cause is due to most likely some kind of lipid-related problem or diabetes or high blood pressure, and which cause the endothelial damage on the arterial side. But in the pulmonary artery, similar kind of factors, inflammatories or infectious or drug or toxin or high flow phenomenon in the case of congenital heart disease, any type of left to right shunt can cause high flow, and high flow over time could damage the pulmonary artery, the very delicate endothelium. And once the delicate layer, single layer of endothelium get damaged, it starts to develop what we call intimal and medial proliferation of smooth muscle cell. And the muscle cell proliferate like scar or keloid formation, and with time, it leads to obstruction of the pulmonary arterioles. And that's why in patients with chronic pulmonary hypertension, severe pulmonary hypertension, you see oligemic in the peripheral lung vessel because the small vessels are all obstructed and the blood cannot really get through, and everything backed up, leading to high PA pressure, tricuspid regurgitation, dilatation of the right ventricle and the right atrium. Well, the way to make a diagnosis of pulmonary hypertension is really, the gold standard is cardiac catheterization. It's an invasive test that you have to go to cath lab, and the interventional cardiologist or pulmonologist would put a catheter, Swan-Ganz catheter, through the jugular into your right heart, and then flow into the pulmonary artery, and then measure the pressure inside the pulmonary artery. The criterion for diagnosing pulmonary hypertension is the mean PA pressure of greater than 20 millimeter of mercury by right heart cath, not by echo or any other means. So the gold standard is really the right heart cath. And then with a normal wedge pressure of less than 15 and pulmonary vascular resistance of greater than 3 units, you fit the criteria of pulmonary arterial hypertension. Pulmonary hypertension can be a lot of causes, and we will get into it. So if you look at the classification of pulmonary hypertension, it's divided into 5 categories. The pulmonary arterial hypertension, which is before the lung, pulmonary venous hypertension, which is after the lung. Then you have pulmonary hypertension associated with disease of the respiratory system, and or hypoxemia. And this is the category that the lung specialist, like our John Asker, will be taking care of most of the time. The pulmonary venous hypertension really are those typical cardiology problems, like mitral stenosis, aortic stenosis, hypertrophic cardiomyopathy. So 1 is very unusual, 2 is quite common, 3 is also quite common, but taken care of by pulmonologists. Pulmonary hypertension due to chronic thromboembolic disease can be taken care of either by pulmonologists, cardiologists, or the general practitioner. Because of the clots built up in the lung, you get the same thing as if the arterioles are proliferating. So this is the condition that you have to treat very aggressively before it develops into pulmonary hypertension. And the last category is the pulmonary hypertension with unclear multifactorial mechanism. This is still in the category that we don't see that often, but we know that, for example, schistosomiasis can cause pulmonary hypertension, and the mechanism is still not very clear. So if you break down these 5 categories into subcategories, there are a lot of new diagnoses or newfound causes of pulmonary arterial hypertension. For example, hereditary. If you have mutation of BMPR2 genes, it can lead to the development of pulmonary hypertension. This is a bone morphologic protein. Or the potassium channel modification can also lead to development of pulmonary hypertension. Drugs. In the past, the weight loss pill fen-phen is well known for causing pulmonary hypertension. Associated pulmonary arterial hypertension causes can be HIV, liver disease, portal hypertension, congenital heart disease, hemolytic anemia, persistent pulmonary hypertension of newborn. A lot of baby born hypoxic can develop pulmonary hypertension, and they need specialists in pulmonary hypertension to take care of. Veno-occlusive disease is another very tough diagnosis to make. So you need both invasive and non-invasive way of diagnosing that particular condition. We talk about the pulmonary hypertension due to lung disease, COPD, sleep apnea, and chronic exposure to high altitude. I have patients from South America, Colombia. They live in very high altitude and develop pulmonary hypertension, and they have to move down to sea level in order to get rid of it before it becomes permanent. And if you look at the progression of pulmonary hypertension, they actually can be quite rapid. In the beginning, there's the pulmonary artery, the lumen is quite large, but with time, because of the proliferation of the smooth muscle cell and fibroblasts, it becomes smaller and smaller. And once it becomes too small, clots start to form. And when clots form, you're in big trouble. So the cardiac output stay pretty steady until it becomes symptomatic, and it will drop very fast. So it's very important to diagnose this condition early and treat the patient early. The prognosis of pulmonary hypertension, especially the pulmonary arterial hypertension, is actually quite poor. In fact, it could be worse than some of the cancers. Look at this. If you're functional class 1 to 2, that means asymptomatic or mildly symptomatic. If you have a diagnosis of pulmonary arterial hypertension, your median survival is only 5 years. That's pretty bad. And functional class 3 is 2.6 years. If you're functional class 4, you're not expected to live more than 6 months. So, and then if you look at some of the bad cancer, ovarian cancer, breast cancer, advanced lung cancer, pulmonary arterial hypertension is pretty much as bad as some of these horrific diagnoses. So it's very important to diagnose it early and treat and refer the patient to specialized centers. And the prevalence of pulmonary arterial hypertension is rare, but the other type of pulmonary hypertension that I talk about, the class 2, class 3, class 4 are quite common. So regardless, you should, as soon as you see patient with evidence of right atrial enlargement, right ventricular hypertrophy, right bundle branch block, right axis deviation, refer to the cardiologist or pulmonologist for evaluation, because you could be saving someone's life. Connective tissue disease is very important. It's been known that lupus can cause pulmonary hypertension, mixed connective tissue disease can cause pulmonary hypertension, systemic sclerosis, like scleroderma, can cause pulmonary hypertension. So a lot of the connective tissue disease, you have to think of pulmonary hypertension, because that is one of the complications of the connective tissue disorder. This is a case that I reported many years ago now when I was at Mount Sinai, a patient with lupus. It turned out to have lupus anticoagulant causing clot in the pulmonary arterioles and ultimately death of the patient. And through the in situ thrombosis, basically clot is forming everywhere, only in the lung, nowhere else. So this is very, very tough to diagnose unless you think of it and then you treat the patient aggressively early on. Another case of lupus vasculitis, all right? Lupus vasculitis, you see the infiltration of the mononuclear cells in some of the arterial and clot forming in others. So you can have a mixture of inflammatory cells and thrombosis throughout the pulmonary arterioles. Toxins. We learned many years ago the weight loss pill Fen-Phen can damage pulmonary arterial endothelium. And that's why that drug was taken off the market. But we still have other sort of similar drug around for like fenfluramine, desfenfluramine. These can cause pulmonary hypertension through the same mechanism of damaging the endothelium. Toxic rapeseed oil, canola oil can lead to pulmonary hypertension. This is definite. And some of the sympathetic sympathomimetic agent like amphetamine, methamphetamine can also cause pulmonary hypertension by causing severe vasoconstriction and damage of the endothelium. L-tryptophan, possible causes like cocaine, St. John's wort, SSRI, the unlikely are the oral contraceptive, estrogen, and cigarette smoking. Well, I have to say the oral contraceptive can lead to thrombosis, like pulmonary embolism, like the case that I showed you earlier, the lady with clot in the central pulmonary artery from taking oral contraceptive. So you have to be careful. It will not cause pulmonary arterial hypertension, which is class 1, but it can cause the class 4 due to like pulmonary embolism. HIV, also associated with the development of pulmonary hypertension. I mentioned about schistosomiasis. Worldwide, it probably is the #1 cause of pulmonary hypertension. Thank God we're living in the part of the world that we don't see too many patients suffering from schistosomiasis. Hemolytic anemia and portal hypertension. When I was at Mount Sinai, I took a lot of the end-stage liver patients waiting for liver transplant, and many of them have pulmonary hypertension. And that is one of the very important diagnoses not to miss. If you have pulmonary hypertension and you go in for liver transplant, you could have a disaster. So almost all pre-liver transplant patient has to be evaluated by pulmonary hypertension specialists. So treat all the reversible causes of pulmonary hypertension first before you give a diagnosis of pulmonary arterial hypertension. And as I said, a lot of the diagnoses belong to the pulmonologist and cardiologist. So a typical screening exam would include EKG, chest X-ray, sleep study. Sleep apnea can lead to pulmonary hypertension due to chronic hypoxemia. And so that is one of the diagnoses you should keep in mind. 2D echo will help you to pick up the right heart abnormalities. Pulmonary function test will help you to find out some of the interstitial or COPD, lung disease. And the functional study is important to help you categorize the functionality of the patient with pulmonary hypertension. The predictor of outcome in pulmonary hypertension is right ventricle. When the right ventricle fails, the patient dies. So it's very important to send the patient to a specialist with the skill and the imaging skill and the knowledge to look at the right ventricle. Most of the patient will be screened by echo. MRI, like what we have here, is superb for the evaluation of the right ventricular hypertrophy and dysfunction. The treatment, I won't get too much into it because this really belongs to the Pulmonary Hypertension Center. I used to run a pulmonary hypertension program, so I'm very familiar with it. But I think right now we should mainly focus on finding the patient early and then treat those that we know how to treat. For example, all the pulmonary venous hypertension should be treated by cardiologists early on. Get rid of the mitral stenosis, get rid of the aortic stenosis, get rid of the hypertrophic cardiomyopathy, then you solve the pulmonary hypertension. Or send it to Dr. John Asgar for the lung evaluation and treat the lung condition, then you get rid of the pulmonary hypertension. If neither one of us could deal with it, those patients then should go to specialized center for the treatment. There are really three main pathways: the endothelium pathway, the nitric oxide pathway, and the prostacyclin pathway. These are the three main pathways. There are many drugs available. Some of them that we're familiar with, like sildenafil and tadalafil, they belong to the nitric oxide pathway. Some of them you're not very familiar, but it's been around quite some time, like the bosentan, ambrisentan, maxisentan. It's been proven to be very useful to treat patients early to prevent the progression of the disease. When the patient becomes very sick, then you need the prostacyclin. And those are very hard and difficult, painful drug to administer, not only to the operator, but also to the patient, because it's very tedious and the patient has to be on it all the time. And when the pump stops, disaster happens. This is a long list of the currently available medication. When I started treating pulmonary hypertension more than 15, 20 years ago, there was only one drug. And over the past 15, 20 years, it's really amazing to see the number of drugs currently available and really give tremendous hope to patients suffering from this horrible, horrible disease. And I think our job now should be identify patients early and refer them early to specialists. First treat the treatable causes, and if we cannot deal with it, then we send the patient to specialized center, and then the patient will get right heart cath, vasodilator study. Based on the result of the vasodilator study in the cath lab, a special treatment protocol will be offered to the patient. When everything fails, you always have lung transplant. So this is a simplified way of describing the treatment algorithm currently available. So in summary, pulmonary hypertension is a serious diagnosis. Unfortunately, also it affects many young women. And when I was running the program, I see a lot of young women suffering from this. For some reason there's a propensity to affect the female more than male. Early evaluation and treatment is key to the long-term survival of a pulmonary hypertension patient. treat all reversible causes of pulmonary hypertension, and many treatment options are available currently, from inhalation to intravenous form of treatment are available. So really there's a lot of availability, and unlike previously, there was only one IV form, and it's very tough to use and very tough on the patient. With that, I'd like to thank everybody, and I'm open the floor for anyone who has any question. I also have my email in case you think of question later on and you want to ask me, and that's my email. And let me see, any question from the audience? Usually I'm the moderator, so it's kind of hard for the moderator to ask myself, the speaker, to question. So I really need the audience to participate here. Teresa, you have any question?
When do you think is the most appropriate time for a primary care provider to refer for the suspected condition?
I think when a primary provider see a patient and with symptoms like shortness of breath, fatigue, early fatigue, and then you do a EKG that, you see a little bit of an incomplete right bundle or right bundle branch block, you should think of pulmonary hypertension. Or you do a chest X-ray, you see the pulmonary artery look very prominent, or you do a lateral view, you see obliteration of the anterior airspace, you should think of pulmonary hypertension. You see clubbing, you should refer to pulmonary, to pulmonary hypertension specialist. I'm glad that I'm one of the pulmonary hypertension in-house specialists in-house, so I'll be happy to help screen out to make sure that we are not missing something obvious that, or we can treat ourselves. And those that I cannot handle and Dr. John Ashcroft cannot handle, we would refer to the specialized center. I know almost all of the pulmonary hypertension center director in the New York City area. So it'll be very easy for me to refer to them. But I think we have to get the diagnosis first. And I think it's important. I think primary care is the gatekeeper. As our group getting bigger and bigger, we're going to see a lot of patients. And I just want the entire group to be aware of this very important diagnosis, and is very treatable right now. We have great drugs, unlike 20 years ago. So I think we should, be responsive to sort of identifying patients with potential pulmonary hypertension. And it's actually good for group practice, because the pulmonary hypertension, once you identify, it's an HCC code. You'll be surprised. There are a lot of patients. I diagnose pulmonary hypertension every day from doing the stress test. And when I do stress tests, I see that they have the early form of pulmonary hypertension, which is exercise-induced, which is great news, right? You don't want to diagnose fixed pulmonary hypertension, which is end stage. So I'd rather you refer the patient early, and then we diagnose them and treat them, and the patient carry a diagnosis, so everybody will be aware to be careful not to miss, sleep apnea, not to miss, systemic, lupus, scleroderma. I mean, all the contributing cause, because oftentimes it goes the other way. When you diagnose pulmonary hypertension, then you go backward. What is the cause? Is it sleep apnea? Is it congenital heart disease? Because you may not think of it initially, but once you have the pulmonary hypertension, you go backward. start to looking for the cause. So I hope I didn't make it too complicated.
No, that's great.
Yeah.
Yeah, but so I have a follow-up question on follow-up. Like, so if a patient is treated with put on medication to treat pulmonary hypertension in the primary care settings, how do they identify whether the treatment is adequate, or like when do they need to send patient back for reevaluation?
Yeah, I mean, I think the treatment of pulmonary hypertension should. I'm not suggesting the primary care specialist should not do it, because I think you do need some kind of provocative test to decide what the treatment should be. So I wouldn't even know until I do the stress echo that the patient has reversible early pulmonary hypertension, and I should treat with some vasodilator like calcium channel blocker, right? I wouldn't just, because of some echo report, going to start treating patient with calcium channel blocker. I need to do some provocative tests first. So I would say that if you see something that's suggestive, on the echo report, it came back say that the tricuspid regurg is moderate to severe, definitely that patient should be referred out for further evaluation. So anything other than minimal or mild tricuspid regurg, I would send out, because I think that patient probably has some form of early pulmonary hypertension, and we need to look into it. Is it from a left heart or pulmonary or other causes?
Got it. Thank you so much.